Good day. I'm Dave Hashey with the Department of Family Medicine at Idaho State University. And today we're going to be talking about improving outcomes and long-term success in HIV patients with a focus on adherence. I currently have no relationships or financial ties to disclose. And as we get started, I'd like to lay out our objectives. There are four major aspects of adherence I want to focus on today's discussion. First is the differentiation between the terms of adherence and compliance that we come across in the literature and our daily practice when working with HIV. Next, you should be able to identify barriers in your practice that will prevent patients from achieving optimal adherence with their regimens. Third, we'll talk about how to assess adherence in the patient care setting so that you can leave today with some clinical skills and some tools that should help you along the way. And finally, we'll discuss strategies, supportive measures, and other means in which we can help our patients improve adherence. Because through all of this, it is a multi-system approach of using the provider, the patient, and the system in which we work in. So let's begin by briefly discussing the terms compliance and adherence. And with this, all the terms compliance and adherence are considered technically similar. And there are a few, subtle differences when we look at the terms and talking about HIV medicine. And when the term compliance is used in medicine, there sometimes is a negative connotation associated with it, that the patient's kind of passively following orders, and that they're submissive and obedient with a care plan, so to speak, that they're being compliant with what the doctor is prescribing, or they're compliant with case management. And it doesn't necessarily establish sort of this relationship or contract between the patient and their provider. And when we look at the term adherence, this term was made popular over the last 20 to 30 years in the HIV literature, where the term adherence sort of surfaced in respects to a more positive approach or a positive relationship between providers and patients. And the term has kind of stuck, and you'll, as you read more HIV literature, you'll come across the terms adherence more so than compliance. But again, the two are relatively used interchangeably, but you'll hear the terms adherence emphasized in more so in HIV care. So as we build on this term of adherence and we look at where we are in 2012 with suitability of regimens, where we are in 2012, our regimens are much more durable and potent than they were 15 years ago. The medications that we use have longer half-lives, higher intercellular concentrations with the use of boosting. All of this has led to better dosing profiles of medications. However, patients that are on therapy still need to be more than 95% adherent in order for the medications to maximally suppress the virus. So when we take a look at that, what does that mean on a patient that's, let's say, on a triplet, taking medication once a day? That means that they cannot miss more than 2 doses a month without potentially allowing for viral breakthrough. If a patient is on a regimen that is BID, that's no more than 3 or 4 doses a month. And so with that, if a patient misses more than that, that allows for viral replication to happen, and with that, potential resistance problems. And when we look at the slide off to the right, or we look at the figure off to the right, this figure shows us data from a systematic review demonstrating this inverse relationship between rates of adherence and dosing frequency or medication schedules. And it confirms what you may already suspect or know, that as regimen complexities increase, adherence rates drop. So patients in these studies that were on once-a-day regimens averaged about 80% adherence to once-a-day regimens. Not in there, of note, there is not much difference between twice and 3 times a day regimens, where this emphasized, 70% compliance in patients that were on twice a day and 65 on 3 times a day. But once you try to create a regimen for a patient that is dosed 4 times a day, adherence is going to drop to approximately 50%. Now, this quote from C. Edward Koop is, I think, crucial to what we're talking about, and we can interchange various words in this phrase as we go along today. But really, drugs don't work in patients that don't take them, and so with that, the questions that we have to ask are, what are the barriers that patients face, who can't take them or won't take them? What are some ways that we can assess adherence, and ultimately, what are the ways that we can help patients increase their rate of adherence? Now, before we talk about barriers to adherence, I want to talk about predictors of poor adherence, and specifically predictors that are central to patients infected with HIV. When we look at predictors of poor adherence, the presence of psychological problems can decrease rates of patients' adherence, such as patients that may have comorbid depression, patients that may have bipolar, schizophrenia, that if their mental health is uncontrolled, then they are more likely to be non-adherent to their medication regimens. Just those chaotic lifestyles can cause breaks in therapy, and it can lead again to non-adherence. Presence of cognitive impairment and neurocognitive decline in patients with HIV is an ever-growing problem in this subset of patients, and remembering to take medications can be a struggle for some patients. Treatment of asymptomatic disease is also a reason patients don't adhere to regimens. If they don't feel ill, why do they need to take a medication every day to prevent problems? And this is becoming more of an issue in HIV medicine as we are treating patients with higher and higher CD4 cells who are healthier and healthier. So patients will be asking this question of I feel great, why do I need medication? Next, patients who do not have good follow-up, discharge planning, or education around their disease will have poor rates of adherence, as well as patients that experience side effects. So again, as we talk about management of side effects and predicting side effects, this is crucial into ensuring patients are able to get through tough times. And then, despite poor relationships and missed appointments, cost of medications and copays, and with the cost of HIV regimens approaching cash price of between $1,500 and $2,000 a month, that can be a big predictor and needs to be ironed out prior to starting. But ultimately, as we look at this figure off to the left, you can note that between the patient, the provider, and the healthcare system, that each variable in this equation is important and can present multiple barriers to optimal adherence. And that's kind of where I'd like to move to next, is talking further about patient barriers. Patients face probably the majority of problems that constitute problems with adherence. We mentioned psychosocial issues, so not just psychiatric problems, but other domestic issues. Do they live at home with family members that don't know diagnosis? Is the patient homeless? What else is going on from, again, a psychosocial aspect of care? Active substance abuse. I mean, you may be working with patients that have ongoing addiction issues, whether it's alcohol, methamphetamine, heroin, and dealing with chaotic lifestyles in those patients or ongoing high-risk behaviors can be problematic. Assessing patients' literacy levels can also help improve outcomes. If a patient cannot read and they do not know that they're to take a medication twice a day with food, they may be taking it once a day without food. So assessing that and approaching that barrier appropriately. Working with patients' daily schedules and travel schedules is also increasingly difficult. Patients may work swing shifts, get up and work early mornings or work late evenings, and they may be 2 weeks on, 2 weeks off. So with these schedules, it can be very difficult with ensuring problems with overcoming these barriers of their schedule. So identifying those early is important in ensuring outcomes. Lack of disclosure to family or friends can lead to isolation and hiding of medications, not filling medications, and so forth. Patients may be skeptical about their drug therapy. They may not necessarily believe in it. They may have misinformation as well. Working with patients, food restrictions, complications, all of that will help bring down those barriers. And lastly, dealing with affordability of medications. This needs to be dealt with usually from the start of working with your state's ADAP programs, checking what's covered on the patient's formulary, understanding co-pays of the patients, deductibles, working with patient assistance programs. All of those can be significant barriers. And the bottom line with this is that you have to work with your team. You have to work with your mental health providers. You have to work with nutrition. You have to work with social work, pharmacists, nursing staff. Have everybody included to identify these that can pose problems. Next, in assessing adherence are provider barriers. Some prescribers may work with overly complex regimens, twice, 3 times a day regimens, when a once or twice daily regimen may be available to the patient. Working with patients, having providers that have a poor understanding of how to assess for adherence, and this can be difficult as well, and we'll discuss this shortly. But going back to the quote of C. Everett Koop, you could interchange the words here, is that drugs don't work in patients who can't afford them. So the misperception of drug cost and insurance coverage, just because a patient has private drug insurance, does not necessarily mean that they have a $25 copay. They may have a large deductible, they may have a cap. So with that, it can be very difficult for patients to work within that system. And finally, our other barriers include poor workflow for identifying and processing refills in a timely manner that may lead to gaps in care, whether that's ordering medications through ADAP for patients or patient assistance, pharmacies getting in medications for patients through their wholesalers, drug shortages. All these things can be difficult. Storage of medication, whether it's in the pharmacy or for patients, likely fewer medications need to be refrigerated, but sometimes medications need to be refrigerated. If patients don't have access to their medications or have access to a refrigerator or need to keep it stored, may pose problems, as well as the neurocognitive deficits that we had alluded to previously. So our next step is assessing adherence. And assessing adherence and determining optimal adherence can be a tough skill to develop. But there are 2 different ways. There are direct ways and indirect ways that can help us. First of all, there is direct measurements. And ideally, direct observed therapy of patients taking medications every day, but that's not necessarily practical. And there may be some settings that you work in that direct observed therapy may be available, but it's just not always, again, practical. Doing blood levels or therapeutic drug monitoring are are options in patients for assessing adherence, whether or not they're taking their medications or whether or not they're achieving blood levels. But depending on where you work, you may not have access to labs that perform routine drug monitoring for HIV medications. They may need to be sent to regional laboratories for analysis. However, what is a very practical way of assessing adherence directly are our disease outcomes. If the viral load is undetectable and the CD4 cells are stable or improving, then that's a sign that the patient is taking their medications. We can also look at other disease markers to determine if the patient is taking a medication. A great example is the majority of patients that take atazanavir will have elevated bilirubin levels. So you can look retrospectively at your patient's bilirubin levels to see that they've been elevated, and then if they begin to drop and the patient's viral load is increasing, then there needs to be some discussion on whether or not they're taking their atazanavir or if they have medications that are interfering with achieving appropriate atazanavir levels. Then our second method is indirect ways to assess adherence. And these are the more practical ways that that can be applied clinically or in the clinical setting. First is self-report and asking open-ended questions. And doing this in a non-judgmental way, allowing for all of the cards to be laid on the table so that the patient and you have the relationship, knowing that it's okay to miss doses. It's not okay to miss doses, but it's okay for them to tell you that they miss doses. So asking the question of how many doses have you missed in the last week or month, whatever time frame you want to use to assess that, as opposed to asking the questions, have you missed any doses in the last month? That allows them to say no. But when you say how many doses, they actually have to think about it, give you a number, think about, okay, did they travel, did they miss some doses, et cetera, et cetera. So again, avoiding that non-judgmental language, such as, you'd really be crazy to miss doses of this HIV medication because you'd just be wasting it. So again, ways to sort of engage this will be asking the same question differently, or having multiple persons ask a question. For example, having the nurse ask it on intake, having the provider ask it during the interview, and finally having the pharmacist, for example, ask it during dispensing of medications. Other indirect methods include pill counts or pharmacy history. It's always good to ask your patients to bring all their medications to their office visits. You'd be surprised at what they have or don't have in their possession. And doing pill counts, it's a simple way. You can also check the labels of the medications to ensure appropriate instructions. And finally, you can also call pharmacies and have them fax over refill history for the last 6 months. This is a very practical way, very low time commitment on your part, but provides a lot of valuable information on adherence. So we've identified barriers. We've talked about ways and skills to assess adherence. Now let's discuss the last step on how we can help the patient improve their rates of adherence. The first is to involve the patient in the decision of selecting their medications. If the patient has multiple options, laying those options out for the patient and allowing them to take as much ownership in their disease as possible. This way has been shown to be beneficial as, again, patients are taking ownership of the disease as opposed to saying, you put me on this medication didn't work, it's your fault. Whereas the patient decides what they want based on side effects, number of pills, et cetera, et cetera. There is some understanding of them directing their care. Engaging in a multidisciplinary approach of using your resources that are available, nurses, social workers, pharmacists, nutritionists, all of that will help sort of distribute the workload and the burden of the time commitment it takes to work with HIV patients and delivering that adherence. Assessing readiness to start. Too often patients are prescribed medications without having all the facts, without necessarily being ready. So with that, the benefit of HIV therapy is not often is it life-threatening that the patient start the medication immediately. And a patient may need to work through several barriers. They may need to take a month to save money for $2,000 deductible, work with their insurance. If they're getting patient assistance, they may need time to collect documentation. If they have mental health concerns, getting it ironed out with their provider and so on. And next, it's our duty to really provide resources for the patients. Being proactive in side effect management strategies, explaining to them when they will expect to see a side effect, whether it's immediately or in a month or 2 months. When will they expect a side effect to go away? And lastly, what are some medications that they can use to prevent various side effects and complications? And believe it or not, pill boxes have the best evidence to support that there's any benefit on these strategies, that pill boxes actually do improve adherence rates. So whether you're able to provide the patient with pill boxes or you're able to provide the patient with bingo cards or Medisets, all those are beneficial. Simplifying the regimen, as we saw from the study, from the systematic review, that the simpler the regimen, the higher the adherence rates. And lastly, anticipating cost difficulties the patient might face, such as, again, insurance deductibles, high copays, et cetera, et cetera. And with that, I'd like to summarize this talk with the fact that before prescribing medications for patients, it's really beneficial to do sort of a full adherence evaluation, identify barriers, because in the first shot that you have with treating patients is usually your best shot at achieving good outcomes. Using these simple, practical tools in your clinical setting to help assess adherence, such as asking those open-ended questions, evaluating patients' labs, talking to their pharmacies, family members, will provide you that insight. And lastly, providing supportive measures such as the pill boxes, simplifying regimens, resources will help the patient ultimately succeed in their drug therapy. Thank you.